Anyone else wants to try? You'll agree with Daniel, or you'll agree with William and Celine. Celine says 12, Julian says 6. I have 5 answers and 69 students. Dual antiplatelet therapy is not used for pulmonary embolism. William, what is used for pulmonary embolism? And provoked or unprovoked is for deep vein thrombosis, by the way. Can have a provoked or unprovoked DVT, meaning they have underlying cause, or you have no real underlying cause. So I have 6 answers and 70 students for a question that is coming to final MBBS. So, okay, so question 1. You want to ask it again? How long should a patient be on dual antiplatelet therapy post myocardial infarction? You have 3 months, 6 months, 12 months. It's one of them. Okay, it's one of them. Good. So I've seen a couple more. Right. So you have 3, 6, 12. People saying different things. All right. So guys, remember, read outside of what we teach as well. And as I stress to you all, make sure you know your guidelines for this, right? So I'll give you all the answer after. How long is a patient supposed to be on dual antiplatelet therapy after a stroke? Crickets. Nobody? How long is a patient supposed to be on dual antiplatelet therapy post cerebrovascular accident? Rima finally says 21 days. Julian says 6 months up to 12. Okay. 71 participants, including myself. 70 of Pauline says 21 to 90 days. You only have 3 answers. Alright, guys, so make sure you're all reading, right? And last question, based on William's responses, patient has a confirmed pulmonary embolism. Was treated with heparin. Is sending them home. What is the medication of choice? They still have the pulmonary embolism. Still there in the vessels, but stable. Okay, well, dependent, right? So it could be a DOAC or it could be warfarin. So it has to be an anticoagulant. So dual antiplatelet therapy is not used for pulmonary embolism. So please don't mix them up. For DVT and PE, you're using anticoagulation. Anticoagulation is different to antiplatelets, which is different to thrombolytics, right? So I would have sent you all some videos, I believe, in those medications, speed farm. So please go and know the difference between antiplatelets, anticoagulants, and thrombolytics. Right. So when you have DVT/PE, So Aliyah is asking me about with warfarin, when do you have to monitor the INR, or am I wrong? So when would you use warfarin, Aliyah? And is warfarin preferred over Adwac? Hey Shania, we got to see your face. Hi. When is warfarin? Right. So if the patient has, we don't want to this, remember earlier, if the patient has valvular heart disease, so the patient could have had a pulmonary embolism as well as mechanical heart valves, which oftentimes that is how it goes. So remember the, yeah, right. So make sure you're all studying, make sure you're all studying. So we'll use anticoagulation in the setting of vein thrombosis and pulmonary embolism. So that's that. The first question, how long should a patient be, a platelet, how long should a patient be post infarction? How long should they be on dual antiplatelet therapy? The answer to that question is 1 year, right? At least 1 year, 12 months, unless they have another event or reinfarction. But for all intents and purposes, all patients post-MI should be on dual antiplatelet therapy for 1 year. After which, what should we do? So the patient had a NSTEMI, a non-ST elevation myocardial infarction, and we put them on dual antiplatelet therapy for 1 year. Right. So after that, we put them on single antiplatelet therapy. Right. So fantastic. Well, studies are actually saying a lot of studies now are pointing towards clopidogrel as preferred or your ADP receptor antagonist, either clopidogrel or ticagrelor. So it can be either one. And in the UK, they actually keep patients on clopidogrel as single antiplatelet therapy. But the point is they're on single antiplatelet therapy after. Whether it be low-dose aspirin, whether it be clopidogrel, whether it be ticagrelor, they go on single antiplatelet therapy. So write that down if you're unsure, right? So after a patient has a myocardial infarction, they should be on dual antiplatelet therapy for at least 1 year, and the recommended guidelines is 12 months. And once they are myocardial infarction free after that, they then stay on single antiplatelet therapy. And that could be aspirin. We use aspirin here. It could be ADP receptor antagonist against the P2Y12 receptor, such as clopidogrel or ticagrelor, right? So that is the questions that you all want to be able to answer after our classes as well, right? I do teach you all a lot, but remember I said guidelines. The second question I would have asked you would have been, how long a patient should be on dual antiplatelet therapy following stroke or cerebrovascular accident? The answer to that is 21 days. So they should be on dual antiplatelet therapy for 21 days, followed by what? What should we do then? What should we do in that situation? Excuse me. Yeah, a patient had stroke and we kept them on dual antiplatelet therapy for 21 days. What should we do after? Julian says continue SAPT for 3 to 6 months. I agree with that. And Gabriel says antiplatelet monotherapy. Monotherapy, antiplatelet indefinitely. Okay. So call it DAPT. We call it SAPT. All right. So dual antiplatelet therapy is for you guys, all extents and purposes. This is what you need to know. Use dual antiplatelet therapy for 1 year post a heart attack, followed by which you switch to single antiplatelet therapy for a heart attack. In the setting of a cerebrovascular accident, you would use dual antiplatelet therapy for 21 days, followed by single antiplatelet therapy indefinitely. So the patient, once they've had a heart attack or they've had a stroke, they will be on at least single antiplatelet therapy for the rest of their life. but there's a period which they should be on dual antiplatelet therapy to mitigate the risk of that thrombotic event recurring again. So for heart attack is DAPT or dual antiplatelet therapy for a year, followed by single antiplatelet therapy. And for stroke is dual antiplatelet therapy for 21 days, followed by single antiplatelet therapy. When we give a patient dual antiplatelet therapy, what medication must we also give them? Not a trick question. And he says I started. You'll agree with Sydney? Sydney's a bright girl. Julian and Selena bright girls. Good. So when you give a patient dual antiplatelet therapy, we have to give them omeprazole, right? Dual antiplatelet therapy usually includes NSAID therapy such as aspirin. And so we have to give them, as well as ADP receptor antagonists, all antiplatelets tend to have some damage to the gut. So we give them omeprazole. The statin is not required as an adjunct to dual antiplatelet therapy. The statin we give not as an adjunct to dual antiplatelet therapy, but the statin itself has a different function. The statin is used to treat your dyslipidemia, particularly hypercholesterolemia. And so your statin is given as a separate medication for a separate purpose. The DAPT, aspirin, and clopidogrel must be accompanied by omeprazole to mitigate your risk of peptic ulcers and so on. Okay, so these are the concepts that I want you all to be very aware of, and I don't teach them in class because I can't teach you every single thing in will. But now that exam is coming closer, I said that before every class I would start to ask you all things to see if you're reading. And if you're not able to answer the questions, is a fair assessment to yourself that you need to be reading more. Okay, so it's not to make you feel bad or anything because it is a lot of information. I know that you all have had exams and surgery. I didn't expect you all to know these things offhand, but these are concepts as well that you would learn on the wards. Right, so make sure that, well, anyway, you're probably off the wards now, but these are things that you should have been paying attention to. And the reason I ask these questions is because, well, we have students now and they don't know anything, right? But the reason they don't know anything is because they're in year four. So it's not their fault. But it's been 2 weeks and they still don't know anything else because they haven't been paying attention to what we do on the wards. So guys, make sure you're learning about the guidelines based medicine. Before I start, because I expect about 3 more people, I have one more question for you. A patient tells you that they have headaches that is unilateral, um, sudden onset, it lasts about 4 minutes. Last seconds to about 4 minutes. It's unilateral periorbital, comes on suddenly. It's 10 out of 10 in severity. And they get this headache. It's associated with runny eyes, runny nose, and redness of the eyes. What type of headache is that? Sounds like it. What if they tell you they get the headache 200 times a day? What type of headache is that? You try. It's not trigeminal neuralgia. 200 times a day every single day. 200 headaches every single day. Migraines doesn't happen 200 times a day. Separate headaches. Erin says Munchausen's. Daniel says giant salad practice. Okay, so the question is, under what category of headaches does cluster headaches fall? Primary, okay, yeah, primary, but under what category or classification of primary headaches does cluster headaches fall? Well, unilateral is not a category of headaches. Okay, I think most people here. So we'll start vascular in a bit. If you had to describe cluster headache, fantastic. Good. So fantastic, Celine. So it is a class of trigeminal autonomic cephalgias. So therefore, this could have been a cluster, but is more under the category of trigeminal autonomic cephalgias, which all present basically the same way. That is a unilateral periorbital headache with autonomic involvement that leads to tearing of the eyes, redness of eyes. So when it happens 200 times a day is actually something we call SUNC. So there are four types of headaches under trigeminal autonomic cephalgias, and that is paroxysmal hemicrania, hemicrania continuosum, SUNC, as well as cluster headaches. So I want you all to know that a cluster headache is also referred to as trigeminal autonomic cephalgia. That is not trigeminal neuralgia. So that's why I told Christina, good try, almost, but trigeminal neuralgia is a specific complication where the patient has sharp, sudden pain in the distribution of the trigeminal nerve treated by carbamazepine, right? And we said that is usually in association with a compressive lesion at the region, like an arteriovenous malformation compressing the trigeminal nerve. But a cluster headache is not trigeminal neuralgia. It falls under trigeminal autonomic cephalgia. Cephalgia meaning headache, autonomic meaning autonomic involvement, and trigeminal being the autonomic nerve involved. So when you're reading cluster headaches, you are supposed to see that it falls under the class of trigeminal autonomic cephalgia, right? So again, guys, I do give you all 99% of what you need to know, but I want you all to have distinctions, okay? I get you all to pass, and you will pass, but I want you all to have distinctions. So when you're going forward, especially those of you who would have finished exams and so on, make sure that you're reading outside of what we do as well, okay? If you want to get your distinction. My things will help you pass with 100% certainty, at least the medicine and surgery component, but I want you all to get distinctions, all right? So make sure you're reading around that. So the DAPT question and the SAP question was simple. Cluster headaches was a little more complex, but the least you should know is that cluster falls under trigeminal autonomic cephalgias, okay? So good job. Thanks for answering. Thanks for trying. And we will have more of these draft sessions before every class so we could test your nice little brains, okay? So, welcome everyone. We're going to start now. Today's vascular. I always say class should be short. Let me not jinx it this time because Daniel said I jinxed it last time and I feel like I always jinx it. So, we'll get straight into it. Good, good. So, these questions are from one of MBBS's books. So, let's get straight into it, right? We're doing vascular today, which includes PAD, varicose veins, and aneurysms. The varicose veins I'll be doing from perspective, it's hardly tested in MCQ. So I'll just be telling you all what you need to know for OSCE, because it's commonly tested in OSCE. But I really focusing on PAD and abdominal aortic aneurysms, okay? So peripheral arterial disease and so on. So nice. Let's start. Good afternoon, everyone. Welcome. Answers to number 1 in the chat, please. Answers to number 1 in the chat, please. Oh, shucks. Sorry, Daniela. Right, number 1, answers to number 1. Right. Number two, answers to number two in the chat, please. Answers to number two in the chat. Okay, good. Number three, answers to number three in the chat, please. Answers to number three in the chat, please. Number three, answers to number three in the chat, please. Good. Nice. Oh, okay. So we have some different answers now. Nice. So we had different answers for number one and we had different answers for number three. Good. Number four, answers to number four, please. Answers to number four, please. Right. Okay, so this is it says number six, but we have it. Let's call it as number six, even though it's number five, right? So number six, answers to number six in the chat, please. Answers to number six in the, oh, well, you need to see the two questions. Sorry. Nice. So number six, answers to number six in the chat, please. Answers to number six. Fantastic. And um, Last question before we teach a little bit about peripheral artery disease is number 7. Answers to number 7 in the chat, please. Okay, good. So we have just a couple of concepts to clarify. Usually you all know vascular very well. So I like to teach vascular for that reason. Um, what is the landmark? What is the the surface anatomical landmark or surface anatomy of the femoral pulse? Any chat? And what's the surface anatomy landmark for the inguinal ring? Is nice, right? And it was not at that point is 1.25 centimeters above that point, right? So good. Just wanted to make sure you all know that because where hernia exam is concerned and where vascular exam is concerned, those two they definitely are going to ask you for surgery. All right. Fantastic. So let's go. Let's teach. Let's make vascular fun. Good, good, good. Right. So good afternoon, everyone. Welcome to our class on general surgery, vascular surgery, that is. Um, very high yield, very, very high yield. I will be teaching you all PAD and abdominal aortic aneurysm, which you more commonly get tested on in MCQ. Varicose veins tends to come for OSCE, but you can get MCQ questions as well, and I do have MCQ questions along it, so I will teach it, but I'll be more focusing on what you need to know from a OSCE perspective for that, and try and kind of brush up on the kind of loose points for MCQ perspective on our PAD and our abdominal aortic aneurysms, or triple E, right? So the first thing we're going to do is peripheral arterial disease from a lower limb standpoint. Peripheral arterial disease, right? PAD, or peripheral artery disease is actually what it is, right? Peripheral artery disease, right? Peripheral artery, doesn't matter. It's of the peripheries. The concept is the same as if you have coronary artery disease, guys, all right? It is always a disparity between supply and demand. Supply and demand of what? Of oxygen. So there's a disparity between supply and demand of oxygen. We know how that works. It leads to ischemia, where you have clots and your body is requiring more oxygen. You can't properly perfuse the tissue, and so the demand outweighs the supply, and therefore it leads to all sorts of manifestations. Now, when we're talking about peripheral arterial disease, from a general surgery point of view, we need to know about two things, and that is your acute limb ischemia versus your chronic limb ischemia. All right, so we'll be speaking now about acute limb ischemia. Okay, so acute limb ischemia is a sudden decrease in limb perfusion leading to threatening the viability of the limb. All right. But what I want you all to know is this sudden does not mean 24 hours. It is in a patient who presents within 2 weeks. In a patient who presents within 2 weeks. Yes. So that is one fact I want you to know about definition of acute limb ischemia. It does not mean that the patient presented in 5 hours or 6 hours. Anything that causes a sudden decrease in limb perfusion in a patient presenting within 2 weeks of the acute event, that is acute limb ischemia. If the patient has had this event going on for more than 2 weeks, then it becomes chronic limb ischemia. So that is one concept I want to clarify. All right. So acute limb ischemia has the most common reason or etiology is actually not a thrombus, but is an embolus. Embolus, right? What is an embolus? We all know an embolus is when part of a clot breaks off and shoots off throughout the blood vessels. So this is the most common etiology of an acute limb ischemia. And for that reason, we have to understand the differences in presentation between an acute limb ischemia, chronic limb ischemia, and also understand the presentation between the two causes of acute limb ischemia, which would be a embolus versus a thrombus. Okay, so there are two causes. The embolus is the most common cause of acute limb ischemia. All right, what is the source of this embolus? Many times, as we would have listed before, it would be cardiac, and cardiac, in the setting of, we know, atrial fibrillation, where you have a mural thrombus forming. We also know that after a heart attack, right? So that's post myocardial infarction, they could have a mural thrombus forming, and of course, patients who have prosthetic heart valves. Okay, so patients who underwent heart valve surgery, they're at risk of acute limb ischemia. Patients with AFib and post heart attack, all because they could develop a mural thrombus in the left atrium or the left ventricle. And that left side of the heart, we would have gone through this many times. If it pumps out a clot, it's going to go into a systemic arterial circulation. It could either go to the brain, we said it could go to the gut, to the blood vessels and cause mesenteric ischemia, or it can even go to the peripheral arteries and cause an acute limb ischemia affecting either the upper or lower limbs. All right. So that's embolus. Thrombus or thrombosis happens in patients with all the other risk factors for thrombosis, as we should know: hypertension, diabetes, atherosclerosis, as well as smokers. And we'll talk a little bit about smokers in a bit. All right. So we have embolus as the etiology. We have thrombus as the etiology. And I want you all to remember that this could also be due to trauma. A patient could have acute limb ischemia secondary to trauma, and this trauma could be iatrogenic. So if the patient has, let's say, the formation of a arteriovenous fistula, this arteriovenous fistula would lead to shunting of blood, similar to your Steele syndromes. And if you have an arteriovenous fistula, let's say in setting of an aneurysm repair, this can lead to hypoperfusion of the limb. All right. So these are three etiological causes of acute limb ischemia. Okay. Now, of course, rarely you can have a paradoxical embolus, right? And we know what that is. We said that is when the patient would have had a deep vein thrombosis. It went from the leg all the way to the right side of the heart, and usually it's supposed to go into the right ventricle and obstruct the pulmonary vessels if it's doing that. But we said in the patients who have a patent foramen ovale, some sort of atrial septal defect, we have that clot moving from the right side of the heart into the left side, and that is a paradoxical embolus, which can now, a deep vein thrombosis can lead to the things that arterial occlusion. It doesn't usually do that. We went through that many, many times before. All right. So that's our etiological causes of acute limb ischemia. So what else do we need to know about acute limb ischemia? Well, of course, guys, we need to know about the presentation. Acute limb ischemia is a clinical diagnosis, and therefore the features that we are about to call are what you need to know. We need to know this patient has a sudden onset of pain. The limb has a sudden onset of pallor. We know that the patient can then develop some pulselessness. We also know that they could become perishingly cold or poikilothermia. We know that the patient could have paresthesia and paralysis. Which of these suggests severe limb ischemia that is limb threatening, and you might have to cut it out? These two. Paresthesia and paralysis suggest severe ischemia. This patient is most likely to have an amputation. Okay, so paresthesia and paralysis are the two worst manifestations of acute limb ischemia. All right, so these are the two, and that's the answer. Okay, so bam. So that's what you need to know about acute limb ischemia there. We all know our 6Ps. And when you go into a vascular exam, guys, all the things that I'm telling you here are the same questions that they're going to ask you for your OSCE as well, if you do get a patient with PAD. But they're more likely going to bring, of course, chronic limb ischemia, but they are going to ask you acute limb ischemia questions as well, because it falls under the same category. All right? So we said acute limb ischemia can be due to an embolus, or it can be due to a thrombus. Usually, when it is due to a thrombus, it is called acute on chronic limb ischemia because that patient is likely to have had chronic limb ischemia ongoing and a thrombus would have broken off. So this is what it was. This is the blood vessel here. This is your, let's say, femoral artery. Oh, I have to show you all the anatomy. I'll show you all the anatomy after. Right, this is the blood vessel here. It's then going to break off and it's going to clot down here. Here. So this is the setting of a previous thrombus embolizing. This patient, however, would have had a previous thrombus. And so when your acute limb ischemia is likely due to a thrombus, that patient is likely to have had a history of intermittent claudication pain. So one big feature to differentiate, is it a thrombotic cause of acute limb ischemia, is that possibility of claudication. And we'll talk about intermittent claudication in a bit when you do chronic limb ischemia. The other thing is that this tends to happen over the hours to days. Now, we said acute limb ischemia is classified as any sudden decrease in lymph perfusion occurring with an onset within 2 weeks, causing the patient to present. The thrombus is the reason that we have 2 weeks as a definition of acute limb ischemia. When it is due to embolus, the patient is unlikely to have had, they will have no claudication because this is so acute. This embolus came most likely from the heart. And this also happens within minutes to hours because of the pathology. That is, the patient did not have a thrombus in the peripheral arterial system, so they wouldn't have had any claudication pain. What would have happened is that the embolus from the heart, the thrombus from the heart, would have broken off and then go into a vessel, and therefore it's a much more sudden presentation with no preceding history of claudication. All right. Another thing in an embolus, and this is my question to you, and this is the question asked to me in my OSCE, and this is what you're going to put in the chat, guys. A patient comes with acute limb ischemia. They say they have pain, paresthesia, blah, blah, blah. He's thinking acute limb ischemia. What is your first, what is the first part of your examination of that patient? Which pulse? So that's not a Doppler, yeah? Radial pulse. Excellent, Chelsea. That is 100% fantastic. That is excellent that you know that concept. The first thing you do in acute limb ischemia is you palpate for the radial pulse. Why, Chelsea? Or anyone else? Fantastic. Atrial fibrillation, right? Now remember, your patient with acute limb ischemia, when you try to assess the pulses of the peripheries of the limbs that are affected, let's say it's acute lower limb ischemia, which we're talking about primarily. When you assess the dorsalis pedis pulse, it will be faint. When you assess the posterior tibial or what have you, it will be faint, etc. So you cannot really assess the pulses. What you want to do first is feel for the radial pulse to determine if it's an irregularly irregular rhythm. If it is an irregularly irregular rhythm, it suggests that this patient's cause of acute limb ischemia is most likely to be embolic secondary to a mural thrombus in the setting of atrial fibrillation. Fantastically, yeah? You grasp that concept well. That question was asked to me in my OSCE. I'm pretty sure it boosted up my marks when I said the radial pulse. Thank you, Dr. Dave Hananan, for teaching us that answer. Right? So that is another thing to look out for. That is, the patient is, of course, in AFib, which can be determined by your radial pulse. All right. In thrombosis, in thrombus being a cause of your acute limb ischemia, a thromboembolism being the cause, this patient has no real embolic source. And look at the history, they didn't have any heart attack in the past. They didn't really have any heart attack recently. They didn't have any atrial fibrillation. They don't have any heart valves. Nothing to say, all right, this should be an embolus from, of course, the cardiac source, which is the most common source. All right. What else suggests a thrombus? The other thing that suggests a thrombus is that these patients may have peripheral arterial disease all throughout, and so they could have decreased pulses in the contralateral limb. Whereas in the setting of embolus, these patients usually would have only the unilateral, the affected limb, the affected occluded artery being the affected limb, the limb with the affected artery, sorry, being having defective or deficient pulses. So these are the differences between an embolus as a cause of acute limb ischemia versus a thrombus as a cause of acute limb ischemia. This is critically important to note because this determines your management. How you manage an embolic cause of acute limb ischemia versus a thrombotic cause of acute limb ischemia is different. And so this is a clinical diagnosis. It determines your history is very important. It determines your management. You need to know the differences between an embolus being a cause of acute limb ischemia and a thrombus being the cause of acute limb ischemia. Okay? They both present the same way in terms of the 6Ps, but the timing is different, the preceding history is different, their comorbidities such as AFib and so on would also be different. All right? So that's that. Somebody is typing in the chat. What's the last row? Can't remember what the last row was. I probably would have told you in the last row that the unilateral pulse, in the setting of an embolus, the only one limb will be affected. That is the affected limb, right? In the setting of a thrombus, it is likely that they would have had widespread peripheral arterial disease. So even though the right leg is the one that has an acute limb ischemia, the left leg may also have some diminished pulses because of coexisting thrombotic disease in that left leg. Yeah? Understand, Karima? You're welcome. The question with the radial pulse was the thing I asked was, if a patient presents with acute limb ischemia, what is the first thing you're going to assess? And that is the radial pulse. The radial pulse is the first thing you assess because you want to determine if this patient has atrial fibrillation. That helps narrow down your cause of acute limb ischemia to being an embolic cause. And so if it's an embolic cause of acute limb ischemia, your definitive management will be different if it's a thrombotic cause.
Doc, I just wanted to add something. So, yeah, you were saying how the embolus would be the most common cause, right? But in Ravi's textbook, I think this change is no longer embolus, but it's now thrombosis. So, I mean, everybody, like all the other doctors, they say embolus as well. So I guess it
Yeah.
just recently changed, but just letting you know that that's what Ravi has.
Well, if Rav, you have that in the textbook and that question come, choose that, right? All my teachings, now Ravi never taught me vascular. Dr. Dave Hananan taught me vascular, who's a vascular surgeon. So this lecture I'm teaching you all is based on a vascular surgeon's perspective. And this lecture I'm teaching you all is based on when I did vascular. So perhaps that is true. But even as of recently, I was talking, Gandhi was talking about because they want to how to do Fogati balloon embolectomy and so on, because it's most likely. But if that is what Dr. Rav Murad has in his textbook, that is your resource, use that, right? Any other questions? right? Good. So next thing is assessing the limb viability. All right. So this is an assessment that you all need to know, and it goes like this. You have sensory loss versus muscle weakness, and then put it like this. So you put muscle weakness here, and then you have, well, sometimes you'll have a Doppler signal, right? And this could be divided into arterial and venous. This is lower yield on the scale. This is to help us determine if the limb is salvageable or non-salvageable. It is based on our sensory loss and whether or not the patient has muscle weakness. And therefore, what does that say? Paresthesia and paralysis ultimately will determine whether a patient is going to have amputation or not. So, if the patient has no sensory loss and no muscle weakness, that limb is viable. The limb can be threatened if they have the toes associated in terms of sensory loss with no muscle weakness, or if they have more than the toes associated in terms of sensory loss with mild muscle weakness. The other thing is this patient could have complete sensory loss, that is anesthetic. So they cannot feel anything, that is anesthetic, and they could have complete muscle weakness, that is paralysis. So no sensory loss and no muscle weakness is category 1. Those associated with sensory loss but no muscle weakness is category 2A. More than toes associated with mild muscle weakness is category 2B. And of course, this is category 3. What do I want you all to know about this? Is that in the situation where this patient has anesthetic or no sensation or severe loss of sensation with severe weakness leading on paralysis, this requires amputation. So I'm very happy that you all got that question correct. All right. This here is surgeon dependent. Any category 2 where they have mild sensory loss with mild muscle weakness, then the surgeon will determine whether or not, based on, let's say, if it's an embolic cause, they might do investigations or what have you. But this is clinical judgment based if it's going to be salvageable, and we call this marginally threatened. So marginally threatened, and this is immediately threatened. Okay, so marginally threatened is 2A, immediately threatened is 2B. Non-salvageable or irreversible damage is 3, and well, 1 is the limb is viable. Okay, if they have no sensory loss, this is viable. You want to treat them with medical management. This is a viable limb. All right, this is in your guide, so don't mind how I write it. I just use this for you all to follow along. So it's 1, 2A, 2B, and 3, and this is how we categorize acute limb ischemia in the set and to determine whether or not it's salvageable or non-salvageable. Okay. So the point is, anesthesia and paralysis amputate that foot. So I'm very elated that you all got that correct. That was very good. First time I taught this last year, most students got that question wrong and they wanted to reperfuse the organ. But when we get back to the question, we'll answer it again. All right. So for acute limb ischemia, we said it is a clinical diagnosis. And so what investigations do we do? We should not really do any because this is a clinical diagnosis. But what investigations may play a role? Actually, let me change that concept. You diagnose the patient with acute limb ischemia. What is the first thing that you do? The first thing that you do after you diagnose the patient with acute limb ischemia is immediately anticoagulate. And the anticoagulation goes like this. You diagnose acute limb ischemia, anticoagulate after your diagnosis. It goes like this. It is immediately going to give them intravenous, note the root of the heparin, IV heparin, at 80 milligrams per kilogram, which is 80 units per kilogram, that will approximate to about 3,000 to 5,000 milligrams. Look at that. That's a huge dose. Pretty sure if you never saw acute limb ischemia, you never saw this dose of heparin. So it's very easy to remember and associate it. So you give them a stat bolus of IV heparin, 80 milligrams per kilogram. That is a lot, followed by a heparin infusion. Heparin, of course, infusion suggests it's IV, because remember, a lot of times we just give heparin subcutaneous, and that would be at a rate of 18 milligrams per kilogram per hour. Okay? So the takeaway here is acute limb ischemia presents to you, whether it be upper limb, whether it be lower limb. If it's acute limb ischemia based on your clinical diagnosis, you are going to immediately anticoagulate the patient with IV heparin 80 milligrams per kilogram, followed by a heparin infusion. Then we can determine whether or not we will do any investigations. All right. So in the setting of acute limb ischemia, really and truly, first thing you do is treat them. But what can play a role, and we'll see where it plays a role, would be that of CT angiogram and MR angiogram, right? These are the two most important, and there is something called digital subtraction angiography, which is basically where they remove the bones and all you see is the vessels, right? So they remove the soft tissue and the bones, and all you see, they subtract all of that, and all you see is the vessels, and that's why it's called digital subtraction angiography. But a CT angiogram and a MR angiogram can be used in acute limb ischemia, dependent on what is your cause, and we'll see the definitive treatment. So CT angiogram is usually the go-to because it's easier done, easier available. So CT angiogram if you had to use an investigation. But remember, for acute limb ischemia, the first thing you do in terms of when you diagnose it is immediately anticoagulate the patient. If they ask you about what's the first thing you examine for, then it would be, of course, the radial pulse. So listen out for how they ask you the question, okay? If they ask you, so what's the first thing you want to examine the patient? You're going to examine the radial pulse and determine if they are an AFib. Either way, the first step in management of the patient is to immediately anticoagulate with intravenous heparin, 80 milligrams per kilogram, followed by an infusion of 18 units per kilogram per hour. All right? Are we abundantly clear thus far, guys? Any questions thus far? Fantastic. Love it. Good. Thank you. So, once we immediately anticoagulate the patient, our anticoagulation is not necessarily going to definitively manage the patient, right? This is still an embolus or a thrombus or thromboembolism that needs to be removed. The heparin will work to prevent further propagation of any clots, but what we need to do is actually definitively treat. The reason that I went through the differences between an embolic occlusion versus a thrombotic occlusion is because the management definitively differs. We said our embolic occlusion is likely in the setting of some pre-existing embolic source such as AFib, post myocardial infarction, etc. Right? We also said that these patients tend to present within minutes to hours with one limb affected, and the other limbs tend to have their reserved pulses because they are unlikely to have a history of underlying peripheral arterial disease. That makes it more likely to be embolic. All right, when we feel the radial pulse, we might say the patient is an AFib. So these are the things that you're looking out for in your MCQ questions, them. All right, I'm telling you how they bring the questions. In terms of a thrombotic occlusion, they will tell you, well, perhaps the patient had preceding history of intermittent claudication. They are known smoker, hypertensive diabetic with atherosclerosis underlying. All right, this patient would have had intermittent claudication, and when you feel both legs, even though the left leg has been acutely affected, the right leg also has some diminished pulses. That is in keeping with a patient who has thromboembolism, and that is what likely led to their acute limb ischemia. Either way, once you diagnose it, you're going to the first thing in management is to give them the heparin. But dependent on whether or not it is embolic or thrombotic, your definitive management will differ. Okay? If it is embolic and the limb is viable, which we said has no sensory loss. We said it was a category 1, no sensory loss with no muscle weakness. Then we would do what we call a Fogati balloon embolectomy. All right. This is when we offer a Fogati balloon embolectomy. The word is embolectomy. So look at that. And we usually associate this with intra-arterial thrombolysis. That is, they go into the artery and they inject the thrombolytic into the artery. Thrombolysis, lysis, breakdown, thrombo, clot. So you're going to break down the clot with a thrombolytic. This could be things like alteplase or etaplase. Your tissue plasminogen activators, as we should be very well aware of what our thrombolytics are. All right. So this is our surgical management and our definitive management of our acute limb ischemia that is viable in the setting of an embolic cause of acute limb ischemia. If it's thrombotic, and this concept is going to apply to when we reach chronic lower limb ischemia, if it is due to thrombosis, then it becomes a little bit more difficult to treat the patient. Because in the setting of thrombosis, they're likely to have had prior limb ischemia, chronic limb ischemia, or prior peripheral arterial disease. And so in these patients with thrombotic occlusion, usually what these patients have is their CT angiogram. So what we'll do for these patients is we have them on their heparin infusion, we give them the heparin, but because of their history of peripheral arterial disease, we have to do a CT angiogram for a few reasons. We need to see what the site of occlusion is. We need to determine the degree of occlusion, how bad it is, and of course, we need to determine, very importantly, inflow and outflow vessels. Right? Inflow and outflow, simple concept to understand. Say this is the artery here, and you have the vessels here, you have vessels here, right? And you have vessels, a vessel here. All right. So the inflow would be, let's say the clot is here. The inflow would be the blood coming down this way, and we're determining if this inflow is sufficient to perfuse the peripheral vessels, and this will be our outflow, right? The vessels, of course, distal to where the clot is. Basically, you need to know the inflow and outflow of the vessels to determine the length of bypass, if you are to do a bypass, or what are the other options. So the first thing in thrombotic is to do a CT angiogram in many instances, and then determining what your level of occlusion is. If it's a short segment occlusion, we can do PTLA, which is percutaneous transluminal angioplasty. What does that mean? Just going to take a stent, balloon inflate. Very similar concept to percutaneous coronary intervention. Okay, it's angioplasty. Angioplasty means you're going to stent the patient and you're going to break up the clot with a balloon. All right, so you can do PTLA, or we can even do intraarterial thrombolysis. But the go-to usually is PTLA, or you could do a combination of both. All right. So percutaneous transluminal angioplasty. That means you're going to break down a clot in a shorter segment. So let's say the vessel is clotted here. That's not too bad. So we could probably break up this clot here, right? And when we break up this clot here with a PTLA, that's fine. But if it's a large segment or a long segment occlusion, then in this case, we'll probably want to do bypass. Right? And long segment is this whole thing clot up here. It might be better off, that might be too much of a big clot to break up. So guess what? We'll just take our vessels and we'll bypass the clot. Okay? A bypass surgery. So PTLA in the setting of a short occlusion, we could just break up the clot with our transluminal angioplasty, stenting and angioplasty. If it's a long segment occlusion, then we can just bypass it. All right. So the importance of determining the difference between an embolic cause versus a thrombotic cause of acute lower limb ischemia is going to help you determine the difference in our management definitively. Either way, the first thing we are going to do is immediately anticoagulate the patient. All right. Good. So what are the complications of this revascularization process? Well, there are a couple things that you all need to know. A couple things that you all need to know is that you could have reperfusion injury, okay? Reperfusion syndrome, and that is a concept of, remember, your tissue was under a lot of ischemia, and now you suddenly revascularize the patient, you're going to have a lot of cell lysis with a sudden revascularization or reperfusion. This reperfusion syndrome can lead to myoglobinuria because you have a lot of muscle cells being broken down. It could lead to hyperkalemia as well because your cells are going to release a lot of potassium, and of course a lot of lactic acidosis as well because of the increase in your tissue breakdown. Okay, so that's one thing that could happen as a complication of our reperfusion, whether it be a balloon embolectomy or whether it be PTLA or whether it be a bypass surgery. When you reperfuse tissue that has not had perfusion for some time, you're always at the risk of reperfusion syndrome. All right. In the setting of this reperfusion syndrome as well, when you reperfuse some tissue, the other complication you need to know about is that of compartment syndrome. Because when you reperfuse a tissue, those muscles can become very edematous because of the blood and so on, right? And that now could lead to your compartment syndrome. And what are your clinical findings of compartment syndrome, guys? This is for you in the chat. Pain out of proportion to the clinical exam. Pain on passive movement. Fantastic, right? So those are the two common ones. Pain on passive movement and pain out of proportional to the clinical exam. Out of both of them, which one of them is more specific? Alicia said pain. Well, yeah, you had two types of pain, Alicia. Is it pain out of proportion to the clinical exam or pain on passive movement? Which one makes you think that this is compartment syndrome? So it's pain on passive movement, right? So pain on passive movement is more likely in keeping with that of compartment syndrome. Okay. So compartment syndrome has pain on passive movement. Which is more in keeping with that picture. Pain out of proportion to clinical exam. And I want you all to remember the compartment pressures on manometry usually more than 30 millimeters of mercury. So, and what is the most common compartment affected in the lower limb? Anterior. Fantastic. Right, so your anterior compartment. Now this is our orthopedic topic, right, guys? I'm not teaching this. Cool. So that's just a kind of by the way there, right? Either way, how do we treat compartment syndrome? I'm asking you all this in the chat. Patient presents with pain out of proportion, pain on passive movement, they had reperfusion. Are we going to treat them? Fasciotomy. Fantastic, right? Fasciotomy and fasciotomy. Specifically, you say fasciotomy of all compartments. Okay. Before your fasciotomy, make sure that you properly hydrate the patients as well. Because when you hydrate them, you're going to flush out all the toxins of rhabdomyolysis and so on. All right. So hydration, but fasciotomy of all compartments, of course, is how we treat compartment syndrome. So excellent. Good. I think that is it. That's it for acute lower limb ischemia. Are there any questions on acute limb ischemia, guys? Any questions on acute limb ischemia? We're clear on how it presents. We know about the 6Ps. We understand the differences between thrombotic versus embolic phenomenon. Apparently, thrombotic is what they have as the most common cause in a textbook. If that's what they have in a textbook, go with that as the answer. But it's commonly taught by many surgeons that embolus or embolism is the most common cause. But of course, medicine changes every single day, which I also have to talk to you all about when we do our mock exam. Anyone knows what antibiotic has been included in our tuberculosis regimen as of 2025? Yeah, so that's why all I need to be reading, right? So moxifloxacin. Yeah, moxifloxacin is a big, big drug. So when we do the mock exam, this is the importance of having the mock exam. By that time, I expect you all to be reading. We'll have like as much updated because the mock exam, I am going to prepare closer to exams based on, what I hear coming or what I might hear coming, etc., etc. So I could kind of gauge it. So that would be fantastic. But yeah, moxifloxacin and TB regimen. Isn't that crazy? Anyways, so no questions. We all clear on acute limb ischemia. No, Christina is clear. Everyone clear? Fantastic. Now there is this concept. I think I have it in my guide. Ooh, I have to go through this with you all. I did not go through this with you guys. I will draw it out after. Right, I think I had everything here. Should have had everything here. I want you all to see this picture here. What is this diagnosis here? What is this patient's diagnosis? The elderly patient had this sudden onset of pain. And now this is how the limb presents. What is that? DVT, right? So acute DVT, but I want the specific. So I think, who has it there? William, yeah. So phlegmasia, right? So this is a phenomenon, and this is actually part of your venous disease, phlegmasia cerulean dolens. Okay, so this is phlegmasia cerulean dolens. Now they always bring this as compared to acute lower limb ischemia. Of course, the big difference is this patient would have had a prior history of venous insufficiency. This patient would have had an acute DVT. Okay, so look out for the difference between acute limb ischemia, which is any setting of either embolic or thromboembolic phenomena, versus phlegmasia cerulean dolens, which is any setting of venous insufficiency. Okay, so that's one way they like to trick you. Don't be tricked by it. All right, good. Nice. So now we can teach chronic lower limb ischemia. Okay, so chronic lower limb ischemia is probably what's going to warrant me drawing out the vessels, right? So let's say we're starting here in our abdominal aorta. When we branch off into the abdominal aorta, we're going to have our common iliac artery here. Our common iliac artery is going to now go in here and send off a little branch inside the groin area here towards the the groin region and the penis and whatever you have there. But then this is going to give this branch here, and it's going to come down all the way into the leg, all the way into the leg. And it's going to reach somewhere around the knee, somewhere around the knee. Now around the knee is going to branch off here, and then here, and here. Okay, we draw this like trash, right? But this is the abdominal aorta here. I just want you all to know this is the abdominal aorta here. Then it's going to give you a common iliac artery. Our common iliac is going to give us our internal iliac, internal iliac. And then it's going to give us from our internal iliac, sorry, not from our internal iliac, from our common iliac, it gives us two branches, the internal iliac as well as the external iliac. All right. So now I can redraw it. So what we're dealing with when we speak about chronic lower limb ischemia, most of the time has to do with the vessels of our external iliac. And I'll just put it off in words for you all guys. So the external iliac is going to become the common femoral. Common femoral is going to become the superficial femoral. It also gives a branch here, the profunda femoris. The superficial femoral is then going to become your popliteal, which is then going to become your anterior tibial, as well as your tibioperoneal trunk. And your tibioperoneal trunk consists of your posterior tibial and your peroneal artery. Okay, so the external iliac is going to become the common femoral, which is going to become the superficial femoral, which is going to become the popliteal artery set behind the knee. Popliteal artery is going to branch off into anterior tibial as well as a tibioperoneal trunk, which has two branches. That's a posterior tibial and a peroneal. Guys, you do need to know this because they do ask you about how the vessels run in your vascular exam. Okay, so you need to know the anatomy of the distribution of the branching off of the arteries of the lower limb. All right. We know that the pulse that we feel is the femoral pulse, and you all said it correctly. What are the four pulses that you feel in the lower limb, guys? You can fit in the chat. Tell me it in an ascending manner, starting distally and moving proximally. Pulses palpated in the lower limb, guys. Right. Good. So fantastic. I think I saw someone started off. Okay, Julian. So the first one is your dorsalis pedis. That is the one on top of the foot, right? Dorsalis pedis. Then you move to your posterior tibial, which is behind the medial malleolus, posterior to the medial malleolus. So it's dorsalis pedis, posterior tibial, popliteal, and then femoral. Okay, so these are the four pulses that you will palpate in your lower limb arterial exam, right? So dorsalis pedis, posterior tibial, popliteal, and femoral. You said the landmark of the femoral is the mid-inguinal point. We said the mid-inguinal point is where you have a line drawn from the aces to the pubic symphysis, so the midpoint of this line, right? This is the landmark of our femoral artery, the mid-inguinal point. What they're going to ask you, these are the two things you need to know, and please know it. So we just said it, femoral artery, and then the landmark of the deep inguinal ring, as you all have rightly stated, but just for clarification, definitely be 1.25 centimeters above the midpoint, not the mid-inguinal point, but the midpoint of the inguinal ligament. And where does the inguinal ligament span? The inguinal ligament will span from the aces to the pubic tubercle. Okay, so the midpoint of a line drawn from the aces to the pubic tubercle, 1.25 centimeters above that line, is your deep inguinal ring. So please do not mix up the surface anatomy of the deep inguinal ring with the surface anatomy of your femoral artery. They ask that in the MCQs, and they always ask that. They are going to ask you that in your OSCE. All right, so good. So now we have a little understanding about the anatomy and so on. I did that because when I'm speaking about what we're speaking about, chronic lower limb ischemia, the concept of claudication depends on the level of occlusion. So Chronic lower limb ischemia. So we spoke about acute limb ischemia. Now we're speaking about chronic lower limb ischemia. They both fall under the aspect of peripheral arterial disease, but this one more so because patients tend to have peripheral artery disease in the setting of thrombosis and atherosclerosis, etc. Okay? Chronic lower limb ischemia, I need you all to understand this, is differentiated into two things. That is lifestyle limiting ischemia and limb threatening ischemia. These are the two categories of chronic lower limb ischemia that you'll need to know. Lifestyle limiting ischemia is what we refer to as intermittent claudication. So it limits their lifestyle, it limits their ability to do things. Limb threatening ischemia means that this patient is at risk of having an amputation, and limb threatening ischemia is what we call critical limb ischemia. So when we're speaking about chronic lower limb ischemia, we're speaking about intermittent claudication versus critical limb ischemia. They act very much like stable versus unstable angina. Intermittent claudication is stable angina of the lower limb. That is reproducible pain on exercise that is relieved by rest. Whereas critical limb ischemia is your unstable angina, that is rest pain. All right. So when we're speaking about chronic lower limb ischemia, which I will now abbreviate as chronic lower limb ischemia, you have intermittent claudication, and you have to know the definition of intermittent claudication for your exams, especially OSCE. That is reproducible pain on exercise. This word is very important to say. Reproducible pain on exercise that is relieved by rest. Okay, so this falls under the category of chronic lower limb ischemia. This intermittent claudication is your lifestyle limiting ischemia. Versus what we have is as critical limb ischemia. Critical limb ischemia is that where the patient now has persistent rest pain. Persistent ischemic pain, I should say, at rest. Okay, this is usually associated with gangrene. All right, commonly dry gang, which can become wet if it's infected. Okay, so chronic lower limb ischemia is divided into lifestyle limiting versus limb threatening ischemia. Lifestyle limiting is intermittent claudication, that is reproducible pain on exercise relieved by rest. Our limb threatening is our critical limb ischemia, and that is persistent pain even at rest. And that usually is associated with gangrene and sometimes ulceration. All right. Now, the concept is the same as for all peripheral arterial disease, disparity between the demand and supply. You don't have enough oxygen meeting perfusing the tissue. Excuse me. Now, the thing about the lifestyle limiting, that is your intermittent claudication, which is your reducible pain on exercise that is relieved by rest, is that the site of the intermittent claudication can determine the level of your arterial occlusion. So let's say the site is at the buttock and the pain and the hip. The buttock and hip has the intermittent claudication versus if you have the thighs versus if you have the calf versus if you have the foot. All right, based on where you having this reproducible pain on exercise that is relieved by rest, that is intermittent claudication, you can kind of determine the level of occlusion clinically. So if it's buttock and hip pain, it's more likely to be more proximal. So you can have aortoiliac disease. So this can lead to that type of claudication. If it's the thigh, what vessels are the thigh? Well, it could be your common femoral. If it's at the calf, it can be a little bit proximal. It could be superficial femoral, or guess what? It could also be a popliteal. So this could be the site of occlusion. Or if it's a foot, of course, it could be anywhere from the anterior tibial, posterior tibial, or your peroneal arteries, right? So based on the site of your claudication, it can clinically help you determine what is most likely the level of occlusion. All right. So can anyone tell me what this triad is? This patient has bilateral buttock claudication with erectile dysfunction as well as absent, or I should say reduced distal pulses bilaterally as well. Good. Seen 10 thing in the chat. Fantastic. Oh, great, great, great. Excellent. So you all know about Lewy syndrome. And where's the level of occlusion in Lewy syndrome? Aortoiliac disease. All right, so aortoiliac bifurcation. All right, and just to draw that for those of us who might not fully understand, this is a bifurcation again. This is the aorta. This is a common iliac, but remember, a common iliac is going to give the internal as well as the external. So yeah, here we have the internal as well as the external. So this is our common iliac. This is our external. This is our internal. If you have clot here, this is the aortoiliac disease. Usually it happens like this in Lewy syndrome. What are you going to have? Patient is going to have reduced blood flow to where? This is all the way up at your common iliac. So where is they going to have reduced blood flow? Externally, they're going to have reduced blood flow to the external iliac, which would manifest as proximal lower limb pain, so your buttock, your hips. They'll also have reduced blood flow to the internal iliac, which you just said supplies your penis. So the patient will have erectile dysfunction. And of course, bilaterally, they have reduced blood flow. The patient would have reduced pulses. And this here is Lewy syndrome. And who gets Lewy syndrome? Which cohort of patients tend to have Lewy syndrome? As is commonly seen. Guys? Hello? You all hear me? Yeah, right. Yeah. Right. So smokers, male smokers. Okay, male smokers. And what do male smokers also get? So they tend to get Buerger's disease. Okay, so Buerger's disease in male smokers is commonly associated with Lewy syndrome. Okay, so male smokers with Buerger's disease, you're probably gonna have some Lewy. So my guys, please do not smoke. It's not good for your lolo. Okay, good. So that's that about the level of occlusion and intermittent claudication. That is important because they can ask you what the level of occlusion is and where the level of occlusion is, especially in your OSCE. Okay, so that's that. Now the thing about intermittent, not intermittent claudication, the thing about critical limb ischemia, so we just did intermittent claudication, is your critical limb ischemia is where the patient has persistent rest pain, right? But this pain is worsened when the foot is elevated. Why? When you elevate the foot, you are going to against gravity. So the blood has to pump against gravity to reach the leg, to reach the lower limb. So this rest pain is worsened when the foot elevated, but it is improved when the foot is what we call dependent, right? When you drop the foot. Improved when foot is dependent. Please understand that this is very different from where you have venous insufficiency. The venous insufficiency, the pain is worse when the foot is dependent and alleviated when the foot is elevated. So that's why patients who are bedbound, we tell them elevate their feet because we want proper circulation back to the heart. Okay. In critical limb ischemia, remember it's the arteries that are occluded. So of course, pumping the blood up against gravity with the foot elevated is going to further reduce your supply and increase your demand. And therefore, this pain would be worsened when the foot is elevated. Critical limb ischemia would improve when the foot is dependent. All right? So that's that. Now, this concept of the foot being elevated and dependent brings us this concept as well that you need to know for your OSCE. That is the Burgers angle of vascular insufficiency. Right? Burgers angle. So what is this concept? It is the same concept. Normally, when you elevate your foot, what is supposed to happen? When you elevate your foot in a normal patient, you are going to retain color. Okay? So what we have in Burgers um, angle is what we call elevation pallor. So normally in a normal patient, their foot will retain the normal color because the blood is able to pump against that gravity and ensure your lower limbs are properly perfused. In Burger's angle, when you elevate the limb, the foot is going to become pale because of course the blood is pumping against gravity harder. So elevation pallor is seen in chronic lower limb ischemia. All right, and that is your Burger's angle of vascular insufficiency. So what the Burger's angle is where the angle at which this elevation pallor occurs. So if you elevate the foot just 15 degrees, let's say you elevate the foot 15 degrees, 15 degrees elevation, and you have this elevation pallor, then this is likely to be what we call severe um, lower limb ischemia. This patient is likely to have critical limb ischemia. Okay, so if your Burgers angle is less than 30 degrees, I believe it is. Can't remember the exact value, but anywhere, let's say 15 to 30 degrees, and your foot starts to turn pale when you elevate the foot just 15 degrees off the bed, then that is suggestive of severe limb-threatening ischemia. Okay, so that's Burgers angle of vascular deficiency. All right, so that is one thing that you definitely need to know for your exams. By the way, on your OSCE, they could ask you about other things for your chronic lower limb ischemia. I will kind of go through that stuff with you closer to your OSCE exam when we go into the mock exam kind of component that I told you all that I'll have, the kind of viva. So we'll talk about that then. But what I want you all to know for chronic lower limb ischemia is unlike acute lower limb ischemia, where you have a clinical diagnosis, in chronic lower limb ischemia or chronic limb ischemia, we do have investigation that we must. In a patient in whom you suggest has chronic lower limb ischemia, your next best step is your ankle brachial pressure index. What is this? This is the ratio of the systolic BP in the ankle over the systolic BP in the arm or the upper limb. All right? So the systolic BP in the ankle over the systolic BP in the upper limb. Your ankle brachial pressure index has a score. The range is normal. The range is mild disease. The range is moderate disease, and there are different sources for this. The range is severe disease, and the range is critical limb ischemia, that is limb-threatening ischemia. Your normal ankle brachial pressure index is more than 1.0, but less than 1.4. Anything that is more than 1.4 suggests calcification. This is not normal. Okay? So normally it is more than 1.0, but less than 1.4. Patients with mild disease have a reduced ankle brachial pressure index that is 0.8 to 1. Moderate disease is about zero point 0.5 to zero point 0.8. Now, there are different sources for this, so just bear with me here. Severe disease is less than zero point 0.5, and some textbooks will tell you critical is less than zero point 0.3. Others will say critical is less than 0.15. All right. Either way, if you have an ankle brachial pressure index of less than zero point 0.3, you're most likely going to have limb-threatening critical ischemia, but the normal is more than 1.0 but less than 1.4. Okay, and I mean, just to make sense of it, why is that ratio sorry, why is that ratio like that? It's your BP in your ankle versus your BP in your arm. If you have a blood pressure in your ankle that is 80, that means that you are not properly perfusing your ankle as compared to a normal blood pressure in your arm of 120. So a reduced ankle brachial pressure index that is less than 1 is obviously going to suggest that the patient has limb ischemia because the blood pressure reaching the ankle is less than the blood pressure reaching the arm. Guys, give me 1 second. Well, good evening. I know, see. What's up? Hi, sorry about that, guys. Right? Sorry. Yeah. Um, Good. So the ankle brachial pressure index is your next best step if you suspect a patient has chronic lower limb ischemia, and this is your normal, which is more than 1 but less than 1.3, and this is why a low ankle brachial pressure index suggests limb ischemia because well your blood pressure in your ankle is less than that in the upper limbs. Okay, good. So the other investigations, so you have the ABPI being the next step, but the other fantastic investigations, of course, that you will ultimately do, especially when preparing for surgery, would be your CT angiogram. And this is your preoperative investigation. And this, again, will the same things that we said it will do for you when you're doing a if you have a thrombotic cause of acute lower limb ischemia, is the same things it's going to give to you in chronic lower limb ischemia. That is the site of occlusion, the degree of occlusion, whether or not there's a short or long segment involved, and the status of the inflow and outflow vessels, right? So it's the same things it's going to tell you, but just in this setting, you don't have to treat the patient as immediately as you do any setting of acute lower limb ischemia. All right. So those are your two main investigations. And well, with the CT angiogram, you can do digital subtraction. And you can also do a little bit about duplex ultrasound, but we'll reserve our ultrasound primarily for our venous disease. Okay? When you're talking about peripheral arterial disease, we're going to do ABPI or CT angiogram preoperatively to assess the level of occlusion, the site of occlusion, the degree, short or long segment involved, and the status of our inflow and outflow vessels. Those are the four things you're looking for in a CT angiogram. All right? Good. Nice. And to finish off chronic lower limb ischemia now, we just have to talk about how we'll treat it. Okay? So we said for chronic lower limb ischemia, there are two categories. two categories, and that is our lifestyle limiting, which is intermittent claudication. And of course, this is lifestyle limiting, but it does not require surgery. What this requires is lifestyle modification and medical management. Okay? So a lifestyle modification will be, of course, controlling your pressure, controlling your dyslipidemia, controlling your sugar, whatever. Of course, patients, if they are smokers, you're going to tell them to stop smoking. You want the patient to exercise as much as they can tolerate, lose weight, all of those nice things that are going to mitigate the risk of further worsening their atherosclerosis. But when it comes to the medications that we can use, guys, this is another indication for dual antiplatelet therapy, right? And in patients with peripheral arterial disease, usually we start them on dual antiplatelet therapy and keep them on dual antiplatelet therapy indefinitely. Okay, so this is why I was asking you about that. Now, there are different guidelines for this, but most patients with PAD, they are to remain on dual antiplatelet therapy. All right. The other forms of medical management, the two drugs that you need to know would be pentoxifylline, which is a phosphodiesterase inhibitor, as well as cilastazol. So these two pop up as medical management of chronic lower limb ischemia. Of course, you want to lower your cholesterol, so you put them on statins. And anytime you're giving a patient that, you always have to add on omeprazole. But this has nothing to do with altering the disease process, it's just for gut protection. All right? But dual antiplatelet therapy, pentoxifylline, cilastazol, these are some of the medical managements and statins that are used in intermittent claudication. Lifestyle modification plus medical management will be your recommendations. Intermittent claudication is when the patient has reproducible pain on exercise, but they have relief when they are rested. Therefore, we manage that non-invasively. In patients who have what we call limb-threatening ischemia, that is our critical limb ischemia, we manage them differently. These patients can lose their limb. These patients are at risk of an acute on chronic limb ischemia, right, which is where they can have the thrombus break off and embolize. These patients require revascularization. Please revascularize if you see in your question a patient with critical limb ischemia. That is, the patient has ischemic rest pain that is worse with the foot elevated and alleviated when the foot is dependent. That suggests critical limb ischemia. Revascularize them. If it is a short segment occlusion, it's the same concept. Short segment, what are we going to do for a short segment occlusion, guys? Same concept as before. Okay, fantastic. You're going to do PTLA. But if it's a long segment, what are we going to do? Right? We just have to do a bypass. Right? Same concepts. Okay? Fantastic. So that is it. Um, any questions on chronic lower limb ischemia? We clear on chronic lower limb ischemia? Fantastic. Right? We'll talk a little bit about amputations and stuff closer to your exam. I'll give you all a little tidbit on what could come for your ski. They like to ask you all about amputations, the differences between wet and dry gangrene, etc. Is there a specific period of pharmacologic treatment in intermittent claudication? I was telling you all, Marquis, that usually these patients with intermittent claudication, they stay on DAPT and indefinitely, usually. Any other questions? Good. So there is this concept, apart from chronic lower limb ischemia when they talk about claudication and pain. All right. So they have this concept of if you have spinal claudication versus venous claudication versus the intermittent claudication. If you see intermittent, it suggests this is chronic lower limb ischemia. All right. So we said the intermittent claudication is seen in patients with thrombo uh, atherosclerotic diseases, and it is reproducible pain on exercise that is relieved by rest. All right. The venous claudication is when these patients have the pain is relieved with limb elevation, which is different to critical limb ischemia. So when you elevate the limb, the pain is relieved in venous claudication. But then there is this concept of spinal claudication. The spinal claudication that they like to refer to is usually that of spinal stenosis. And a spinal stenosis is where the patient tends to have their pulses present, but very, very importantly, is that the patient has to flex the spine to relieve the pain. Okay? And anyone knows what is this called? There's a picture of a man in a grocery shopping cart sign. Fantastic, right? So that is where the patient is hunched back over the shopping cart to relieve their back pain. Okay? So don't mix up spinal claudication, which usually has no real, in your question stem at least, the patient will likely have no real sign of arterial disease or so on. With your venous claudication, which is where the patient will have limb elevation, relieving the pain, and your intermittent claudication, which we just spoke about. All right? So that is that. Good. So once no questions, we can answer our questions and take a break, teach aneurysms, and I'm just gonna like show you all what to know about venous disease, right? Because really and truly it's hard. They come for MCQs. The MCQs that I have here, what I've seen in the past, but it hardly comes in detail at least. But we will go through it. So number one, answers to number one in the chat, please. Answers to number one in the chat, please. Excellent. So now we understand why a EBPI of more than one is going to be normal. If it's less than one, then that is definitely abnormal. That means that your legs is not getting as perfused as your upper limbs, and that shouldn't be so if you have normal heart function and normal vessels. Okay, so great. The answer here is indeed D. A normal ankle brachial pressure index is greater than or equal to 1, and usually 1 to 1.3. Right? Nice. Number two, answers to number two in the chat, please. Answers to number two in the chat, please.
Yeah, that's all.
Exceptional. So this is a 60-year-old with coronary heart disease, diabetes, and hyperlipidemia. He's now finding it increasingly hard to walk due to the gradual increase in intensity of the cramping pain he experiences in his right leg on walking, which is relieved by resting a few minutes. Oh, guys, also there's the concept of claudication distance. So a claudication distance is basically how far you could walk before the pain comes on. And obviously, the shorter your claudication distance, the worse your disease and the more likely you are going to progress to critical ischemia. Because if you're walking 5 miles and then a pain comes on, as compared if you're walking 5 meters and then a pain comes on, obviously the patient who's walking 5 meters, they have more severe disease. All right. So that's a claudication distance. It's the distance you walk before the pain comes. But anyways, in addition, he tells you the cramps started to occur at night when he is sleeping. Okay. On examination of the right leg, you notice that there's a punched out ulcer on the right heel. and you suspect that he has critical limb ischemia because he has diminished pulses. So the most appropriate next line investigation in terms of chronic lower limb ischemia, your best first line investigation is ABPI. Fantastic. If they were to tell you which investigation this patient is being worked up for surgery, which investigation would he like to do, then it would be CT angiography. All right, fantastic. Right, so number three, answers to number three in the chat, please. Answers to number three in the chat, please. Nice, exceptional. So this is a 67-year-old woman admitted with severe limb ischemia. They ask you to report your findings, which two of the following suggest severe limb ischemia. And we said this patient, the most severe would be paresthesia and paralysis out of the options here. And that is sensory loss and muscle weakness. If the patient has paresthesia and paralysis, limb is unlikely to be salvageable. So now we're going to answer number 4 and 6. And I was pretty proud of you guys. So this is a 56-year-old vagrant, my bad, a 56-year-old homeless man who presented to the ED with a severe pain in his right leg, which started over 12 hours ago. On exam, his leg is pale in color in comparison with the left. So notice it is pale in color. It is not purple in color, as you would see. Now, although you can have purplish mottling, in acute limb ischemia, you're thinking if it's purple, you want to kind of be wary and make sure it's not acute um, DVT and cerebral phlegmasia cerebellar dolens, right? Well, let's watch the entire question. The right leg is pale in color with the left leg comparison, and he has fixed mottling. His leg is cold, so it's perishingly cold, and he has absent pulses. So he has pain, pallor, perishingly cold with pulselessness. And they also tell you he has no sensation and unable to flex the muscles. So this patient has pain, pallor, pulselessness, perishingly cold. This patient also has paresthesia, almost anesthetic, and paralysis. And so this is acute limb ischemia. His heart rate is 85 beats per minute and regular. He's apyrexial. So this patient has B acute limb ischemia. Now, there are tricky questions, and I'm going to use this question to kind of tell you all. Again, this patient, based on this history, it might be more difficult to determine because they didn't give us enough clues. Is this acute limb ischemia secondary to an embolic phenomenon, or is it acute limb ischemia secondary to a thrombotic phenomenon? Usually what they would tell you is the patient probably had AFib and therefore it will be embolic. But if the patient has a prior history of claudication, then your answer is that this is acute limb ischemia, and that is usually acute on chronic limb ischemia, right? So you have acute limb ischemia, you have chronic limb ischemia, and acute on chronic is where you have usually pre-existing thrombotic disease, pre-existing chronic ischemia, and then that thrombus embolizes. So look out in your question stem where the patient had a prior history of claudication, pain, rest pain, etc. That suggests that it is acute on chronic. That suggests that your cause is likely a thrombotic occlusion, thromboembolic occlusion, rather than true embolus from a known source. Okay. How will we treat this patient? Number 6 answers. Fantastic. So we said paresthesia and paralysis. This leg is no longer salvageable. We're going to amputate. Okay, good. And number 7. So this is a history of, this is a 50-year-old woman with a history of AFib presenting to ED with sudden onset of pain in the left forearm. Pain started 3 hours ago, increasing in intensity. The left forearm is cold, pale, left axillary pulse is present, but her distal pulses are absent. Right, movement and sensation are intact in the left hand, no history of trauma. So this is acute upper limb ischemia. Whether it is acute upper limb or acute lower limb ischemia, the treatment is the same. You are going to start heparin infusion, and in this case, you're going to send the patient to theater for vascular intervention because this is likely in the setting of embolic phenomena. So this patient is not going to be heparin and then CT angiogram. This patient in the setting of embolus is going to be heparin and straight to theater for a Fogati balloon embolectomy. All right, so A is the answer here. Fantastic. Good. Any questions on acute limb ischemia or chronic limb ischemia? If not, we'll take a 10-minute break, come back at 8 to 8. Any questions? We clear? Fantastic. That's good, Aliyah. Happy to hear that. Good. So we'll start back at 8:08 p.m. Good.
But I real scaffold to be missing that damn on that scaffold supposed to end up on the news and thing. Yeah, yeah, yeah. But waiting on that scaffold may they put on somewhere for long. That might move out years now and they somewhere you may take it now and bring it away. Stand up, yeah, yeah, yeah. Mm. Then, yeah, they're supposed to back it on.